all the doctors who joined us. I'm Dr. Shweta, and I welcome you all to the Cme India program on neuromuscular ultrasound in the clinical neurology, the third eye. I would like to welcome Dr. N.K. Singh, sir. Sir is the Director of Diabetes and Heart Research Center, Dhanbad. Sir has also been the chairman of RSSDI Jharkhand from 2019 to 2023, executive member of the National RSSDI from 2022 to 2025, ex-governing body member of the National API, ex-chairman of the API Jharkhand and CCD SIBJ. Sir has edited Millennium Books of Medicine, Associate Director of Postgraduate Medicine 2021, edited monograph on COVID by the ICP API 2023, over 40 national and international publications, admin and founder of the CME India WhatsApp group, editor of cmeindia.in, editor of diabetesdhrc.com, and Sir is fellowship from the WHO. I welcome you, sir.
Thank you.
I would like to welcome Dr. Akash Singh, sir. Sir is the Senior Consultant of Medicine, Diabetology and Non-Interventional Cardiology from Vadodara, Gujarat. Sir has been a part of multiple national, regional and state conferences as faculty and speaker, principal author in several publications in national and international Indian journals, reviewer of the International Journal in Diabetes. Sir has been also a book author in the Management of Diabetes Mellitus, a complete practical guide. I welcome you, sir.
Thank you.
And I hand over the session to Dr. Akash Singh, sir, to take it forward.
Thank you very much.
Welcome first, Dr. Akash. Today, really something interesting session. Many of us have never heard about the neuromuscular ultrasound, and at least in my practice, I have never advised any person or any patient for this. So, as you know, this neuromuscular ultrasound is a technique which has been found to augment our diagnostic capabilities. And I think this is a basic understanding of ultrasound technology and relevant anatomy is very important. And Dr. Ujjwal, today's speaker, has done I think, a very important training very recently abroad. And then he's also doing some courses at AIMS Delhi. So this is very important technique now for neuropathy, myopathy, and motor neuron disease. So Akash, you also welcome Dr. Vijay Patni, our all panelists. And then to hand over to the Dr. Ujjwal. Akash.
I welcome you all basically for this important session on neuromuscular ultrasound in clinical neurology, a third eye. This session will be taken by Dr. Ujjwal Roy, who is a neurophysician. He has done his Digimed neurology from Bangalore Institute of Neurology, Kolkata. He worked briefly as resident in prestigious AIMS, New Delhi, and GTB Hospitals, New Delhi. Fellowship in Internal Pain Management from Zadia, Kolkata. He is a member of many prestigious bodies, including API, Indian Academy of Neurology, American Academy of Neurology, Indian Epilepsy Association, and Movement Disorders Society of India. He has more than 25 peer-reviewed international papers as first author to his credit. He is also reviewed to many international journals, including prestigious neurological sciences by elsewhere. He has presented many papers and delivered lectures in many national and international conferences of neurology. His main areas of interest include interventional pain management in neurological disorders, neuromuscular ultrasound, neuroimmunology, movement disorders, including use of botulinum toxin in various neurological ailments. So this is a very, very important and very unique topic which we are going to listen today, basically. Can I have the CVs of the moderators of this session? The moderators of this session are Dr. Rajan Chaudhary. He's a director of Chaudhary Imaging, Patna. He's an MD in radiology from University of Bombay with gold medal, Vice President, Joint Secretary of Radiological Society of India, Bihar, several years. Professional affiliations from Indian Radiology Imaging Association, IMA, ANEI, presentations in various topics like imaging in epilepsy, advances in CT imaging, non-cardiac, etc. Gold medalist and first student in MD radiology diagnosis, first student in physiology. Can I have the CV? Dr. Namrata Chauhan is also moderating the session. Dr. Namrata Khandelwal Chauhan is DM Neurology Gold Medalist, MD Medicine from Ahilya Vishwadhyaya, Indore, trained in epilepsy and VWEEG at Sri Chitra Tribunal Institute, and Medical Sciences, Trivandrum. Dr. Namrata has worked as consultant neurologist at Apollo Hospitals, Guwahati. Dr. Namrata has two international papers published in 2012 2014. The research and analysis of causes of stroke in young tertiary care neurology centers in East India with special emphasis on vascular imaging, areas of excellence, epilepsy, headache, stroke, neuromuscular disorders, Parkinsonism. So I think we are ready to go. I request
Yeah,
Dr.
but
Vijay,
Akash, you also introduced Dr. Vijay Patni. I think I
uh,
think.
Dr. Vijay Patni is also moderating the session. He is HOD Diabetes Wellness Clinic, Kolkata. He's member executive advisory committee of ACP India, India Society of Hypertension, CCDSI, ISCM, DRWA. He is a very, very avid researcher and has many articles and chapters, including independent studies in journals and books. And he is an innovator as far as the study clinical research is concerned. He has several awards and achievements, including fellowships of Indian Society of Hypertension, Indian Society of Medicine, American College of Physicians, and Diabetes India. And he is one of the best speakers on the national platform, and we hear him practically in all conferences across India. So, uh,
Yeah.
so I
So
think
I think formally I again invite our today's speaker, Dr. Ujjwal Rai, so he can share the slides and start the presentation.
Okay, so at the onset, I would like to thank Dr. N.K. Singh sir and Dr. Akash Singh sir, and also Dr. Namrata, who has been very long association. She has been my senior in Bangalore Institute of Neurosciences. But it's like after passing out, never met her. So it's good to meet at this platform actually. So uh, so actually it started. Just I would like to share a few words and lines how it started actually. All of this way back in 2017. I was seeing a patient actually, which was deemed to be a case of carpal tunnel syndrome, and has had seen already a neurologist. There was some nerve conduction study was there. He was carrying a nerve conduction study in which there was some delay in latencies, and there was some amplitude decrease also of the median nerve, and it was a deemed case of carpal tunnel syndrome. But the patient landed to me, and somehow I felt that it's not carpal because there were not typical symptoms there, and rather I would call it as a median neuropathy. Even the NCS was also not very much, conclusive of carpal tunnel syndrome. But then I did not have much to do. I just prescribed some gabapentin as we all do, pregabalin, and send him back. Patient was not very much, most likely was not very much satisfied, and went back to some pain specialist in Bombay. And there they did a neuromuscular ultrasound and then found that it was a case of pronatatory syndrome. The median nerve was compressed in the pronatatory. So I was very much frustrated. So it's like 2017. Now it's like 7 years back. So I thought that I have read this much of anatomy, this much of neurophysiology, and I have done so much of NCS, but still I could not diagnose this condition. Uh, then I started, going to the radiology people and trying to learn. Then from pain people I learned, and then I went to the United States to do this fellowship. I think it was not mentioned in the slide, but I did with one of the pioneers in this field, Professor Michael Cartwright, who is pioneered in this field. And I also did a fellowship in pain management, so that I could be more versed with procedures and all. Because in neuromuscular ultrasound we are not taught with all these kind of procedures, but slowly we as a neurologists we are entering into these kind of things, and now I think we are around a dozen of people in country. We are doing these kind of things, and believe me, it helps a lot. After my lecture, everyone will agree to what I am saying now. So, neuromuscular ultrasound is an emerging diagnostic subspecialty field. It focuses disease of nerve muscle, as we all know, and it's distinct from the MSK. So, MSK, like musculoskeletal ultrasound, it focuses on traumatic and degenerative changes of tendons and synovial joints. But we have to understand that the mother is the MSK only. So it's the mother, but the child is NMUS. So the high resolution ultrasound allows definitely to study the peripheral nerves, and like anatomical changes like inflammatory and compressive neuropathies. Uh, it is also possible to image fasciculations, and fasciculations, it is 100% sensitive. Suppose you are giving a needle, you're doing an AMG, so it's not that much sensitive. But fasciculations, if you are doing the neuromuscular ultrasound, it's 100% sensitive. And also in fibrillations, now we are doing it. Yesterday only I had a case in which I found out the fibrillations in that patient. That was a case of amyotrophic lateral sclerosis. And atrophy and hypertrophy are also readily measured as changes in quantitative muscle echo intensity. Now, as we all know, seeing is believing. So if you see something, you definitely believe that yes, it's there. So what are the indications? So it's like diagnostic indications and intervention indications. For diagnostic intervention, definitely we know, as I already mentioned, for nerve and muscle, and for interventions. Like suppose someone asked me that what intervention you want to do. You want to do a blocks? Are you an anesthetist? You want to block something? But believe me, it helps. How it helps, I'll tell you. A patient came to me 1 week back with some diffuse, pain in upper limb, and that was in a distribution of lateral antebrachial cutaneous nerve. Now, because I have been practicing it since last around three years, so I was damn sure this is LABC, because that patient had already seen a neurologist, and somehow prescribed just gabapentin, pregabalin. As we all know, everyone would do that only. But no one could think that yes, this could be a LABC actually. So I scanned the LABC. There was a small, a mass sitting over the LABC just besides the brachial artery, as it just crosses the brachial artery here, just beneath the tendon of the brachioradialis, the biceps tendon. So I was very much fascinated to see that thing, and then I sent this patient to a surgeon so that it could be resected, and I think he will be free of symptoms. So how I did that? Yeah, this pain is due to that only, and not just functional pain, as we all understand, as we all diagnose. Many times, at times we just vaguely we prescribe some duloxetine, some maybe paroxetine, maybe pregabalin, maybe gabapentin. So I blocked that LABC at that site only, and the pain was totally gone. So you have done some magic, doctor. I have not done any magic. Magic will be later. So first, what is important, that yes, you are localizing that yes, this pain is due to that only. So block is also important for neurologists, not only for a anesthetist. And definitely hydrodissections. I now usually I have a load of around maybe 10 hydrodissections per week. Yeah, that load I have. And hydrodissection release in carpet tunnels are doing wonders, and have been several papers now where they have shown, even there have been comparisons uh, from the 5% dextrose versus corticosteroid and things like that. The papers are coming up. Now, what are the inadvertent intraneural intravascular injection? When I'm LABC, it's very near to the brachial artery, very near to the tendon. So if I am like, anyone who could argue that if you know the landmarks, as we used to do in our anatomy days, if you know the landmark, you just go on and just give the injection and you can see. But then there's a risk of inadvertent intraneural intravascular injection, and that can damage. That can sometimes be catastrophic. Earlier, when there used to be these kind of blocks like stellate ganglion blocks, anesthetists used to have catastrophes, and patient would land into a death table directly from the OT table. It's important always to give these things to give these blocks under ultrasound, as is the routine practice nowadays with anesthetists. Another thing is that assessment of respiratory and diaphragmatic function. I'll come to this. This is a very important thing actually now coming up, and I am using it regularly for my ICU of these patients. Uh, And as I said, guiding therapeutic injections of botulinum toxin in muscles and salivary glands, hydrodissections in the carpal tunnel syndrome, biopsy of nerve and muscle, and ultrasound guided EMG needle placement also sometimes. That if sometimes what is there is some change in anatomy, there are some variations in anatomy. So when patient does need not be pricked again and again. So if you have that ultrasound, even in doing EMG, that's easier actually, because you see the muscle, you just guide it, your needle. And sometimes, as in even in Botox administration or EMG, if you have that, this muscle is not fibrous, and suppose their muscle is fibrous, not Botox will also not, neither the EMG will work. So if you have these kind of tools, then it's very easy to where you want to go, where you are going, it's all visible. I'll have some videos I'll show you. Ultrasound images created based on returning echoes and their temporal acoustic properties. We all know this piezoelectric effects and things like that. What happens in diseased muscles? In diseased muscles, actually, there is replacement of fat and fibrous. So you are seeing this muscle with the ultrasound. It's a virtual biopsy, believe me. You are seeing that yes, this muscle is being replaced by fat and fibrous tissue, and what amount of fat and fibrous tissue it's being replaced. It gives a whitish appearance, and there has been a grading also. That's called the Hickman grading. I'll just come on onto this. This just a diagram to that how many echoes are actually coming. So if it's like more of fat, fascia, things like that, so more echoes, and so it will be hyperechogenic. The muscles which are atrophic muscles, which are which have degeneration, they be hyperechogenic. What are the diagnostic frequencies? So obviously it's a higher frequency probes. It's not the routine probe that we use for abdominal ultrasound. It's definitely higher. And I think 4 to 15, 4 to 18 sometimes. I have got a probe of 4 megahertz. That's good probe. And whatever high end you go, but what you lose actually, you lose depth actually. So if you are going at suppose a frequency of 20 megahertz, so you lose the depth. So you will be able to scan the forearm very well, but then if you want to scan the thigh, then you have to go for a lower frequency probe. So that's the principle. These are the what is normal. So every one of us will agree this is a endoneurium, perineurium, things like that. And you can see here. You can see this beautiful nerve here. There's the epineurium, then the perineurium here, and there are different fascicles as you can see. These are dots are fascicles actually, and these are the normal of these nerves actually of the cross sectional area. This is a very important parameter, cross sectional area. So pathology happens. So loss of fibrillary thickening and hypoechogenicity, perineural fat standing, and there are sometimes I really get referrals from the plastic surgery department, from the orthopedics. I regularly refer because I want to know what is the functional functional status of the nerve. That I do with the EMG and nerve conduction study. And they also want to know along with that how much compression between these nerves. So if I said that there's amplitude is 0 of the median nerve is like median neuropathy, I'll just say. But is that nerve has a has a neuroma at some place? It's just like total avulsion is there. So this cannot be substantiated on the nerve conduction study and EMG. But when we use ultrasound along, we have a third eye, as I said. And what are the parameters for any entrapment neuropathy? Now, when we talk of carpal tunnel syndrome, I use this muscular ultrasound as an adjunct with nerve conduction in all of my patients. Ask me why. So the reason is that if you have this ultrasound, why this technique has not gained that much of popularity? The reason being because neurologists have not taken up this field. Now they are taking up. When I was in the US, believe me, every department, each and every department had one neuromuscular machine from the Campbell. So that Campbell machine has got the and the neuromuscular ultrasound is also integrated in that machine. So in all the centers in US now they have the neuromuscular ultrasound. People are trained. One trained person is definitely there. One neurologist has been trained in that, and he is a most likely electrophysiology person, and he is doing all the electrophysiologies, and along with that neuromuscular ultrasound wherever required. So that should be the protocol, and slowly we are moving towards it. Maybe after maybe 5 years, 10 years, this will also be a routine protocol in India also. In Europe also they have done. I was there in Europe for a couple of weeks last year, and I saw it in Netherlands. Dr. Van Elfen-Nens. She is maybe you can tell a father of this neuromuscular ultrasound in Europe. And how does it help? So I was coming to that. So if you are doing just the ultrasound, it's 95% sensitivity. So 95% sensitivity, for that the radiologists are like 95, 95, 95. So I will come with a nerve conduction study and I will say it's also 95, 90 to 95. And then we will all quarrel. This is not required. What is required? We will combine the 95 with the 95. And now the sensitivity will be as high as 99%. Believe me. In patient, there are many sometimes missed when we do study, especially patients who have come to us early. So, the first thing that happens to patient is the symptom. Please try to understand. But sometimes these NCS come normal or is like and we just not serious dysfunction. No, that's wrong. When we do this in ultrasound, believe me, in 50% of the patients I have found out something. And that's the reason that we should always combine. So it's not that. So why did not come up for the last around years? Because this was a radiologist. So no patient will still. I have a poor NCS. Why I'll send to a radiologist? But if I have it with myself, I will do the NCS and I'll just do the ultrasound because that's a bedside tool. That's a focus. That's a point of care ultrasound. Okay. So coming on to what are the parameters? So increased cross-sectional area, number one. So for the median nerve, I take the increase the cross-section area 12 as the cutoff. But there are different things. So 9 to 12 is the range. Sometimes if it is less than 9, we cannot take it as a CTS. If it's like more than 12, definite CTS. In the mid, we have to do things like NCS, EMG, and we have to ask about other things. And then see whether this is it. But if it is like more than 12, 13, definitely it's proven. Other things like hypoelasticity, flattening, hypomobility of nerve, that's in later stages. And one more very important thing which is not mentioned here is that increased vascularity. So sometimes what happens, there is just increased vascularity. CSA will not increase, cross-sectional area, the increased vascularity. And then we will diagnose it sometimes in rheumatoid arthritis. I had a patient today of rheumatoid arthritis, and this patient was diagnosed by the nerve conduction study as a plain case of CTS, carpal tunnel syndrome. But when my patient did the ultrasound, started because I also did the ultrasound, so it was just maybe 10, 11. He said, "Sir, it is not CTS. I'm not 100% CTS." The thing is that you have to consider things also. So when I did the vascularity, it was increased, damn increased PDI actually. So power Doppler was immensely increased. And so we have labeled this patient as a carpal tunnel syndrome, and we have also opted hydrodissection for this patient. Now this is a flowchart of recommendation of nerve pathology workup. So like initially, like if it's focal diffuse infection, it's a focal infection, definitely you should go for ultrasound. But there is a big catch here. If there is even diffuse affection, go for ultrasound. It will help you. Ask me how. So yesterday I had a patient of mononeuritis multiplex, and someone said that it's actually CIDP. So actually the patient had presented very late, and when I did the Edwin did the NCS, there was very subtle findings of mononeuritis multiplex. Grossly, it looked like it's symmetric neuropathy, but because it was advanced. But when I did asymmetric swellings in the ulnar nerve and also in the common perineal nerve. So I advise this patient for a nerve biopsy, and most likely it's gonna come. Actually, then after that there was hypoaesthetic patch also. So most likely it's gonna come leprosy. We have already started for leprosy, and that's where it helps in diffuse affection also. It's not only the focal affection, but it helps in the diffuse affection also. And obviously, in classification of nerve injury like neuropraxia, exanthemesis, neuroentemesis, things like that. These are the muscle changes distal to the level of entrapment. So I'll come to this a bit later. Ultrasound is increasingly used in diagnosis of CTS. Already I explained that it's 95 and combine both, so it comes out to be 95 to 98%. And in MPS and lysosomal storage disorder, it's like 92% sensitivity. CMT1 thickening vessel. So very important. Patient came to me 10 days back and everything was absent. Nerve conduction study totally absent. What do you do with this patient? I have nothing to do. But then I did the ultrasound. So there is a pattern of thickening in CMT, and then we know that it's the case of CMT. But otherwise, it's all absent. Patient has come with weakness. How do you know that this is gonna, this is a older illness, or no? Patient has now, because patient was complaining that I have increased weakness since last 2-3 days. Like I have some grip problems. When I examined, it was like 4+4, maybe 4 weakness of the upper limbs and all. NCS is totally absent. So this actually, dazzles the neurologist, because the patient had hammertoe also. So I was sure that because we have seen these cases, so we know that yes, this may be a case of CMT. Sometimes the lower limb is totally absent and upper limb is very decreased. But if you just give this NCS to maybe a person without history, this patient may land with IVIG. Believe me, if you just give the NCS and do not tell history that yeah, this is the history of the patient. Unfortunately, I had the history also, and I did the ultrasound. There were classical thickening were there in the nerves which are documented, and in deeper nerves actually, like tibial, like superficial peroneal, and things like even medial nerve are thickened here. So in leprosy, what happens generally, the nerves which are superficial nerves, those are more thickened than the deeper ones. But here the deeper ones are also thickened. Coming on to SCIDP, Lewis nerve syndrome, multifocal motor neuropathy, in each of them actually this neuromuscular ultrasound helps. And already I have discussed about these cutoffs, 12, 13 I have already discussed. But believe me, it's not always about cutoff. It's about combined effort. So it's like you also to think about hypoechogenicity, about flattening. Achha, one more thing. The median nerve enters here from the pronator pronator quadratus to this tunnel. So there is a very muscle here, pronator quadratus. So you also measure the cross-sectional area here, and then you measure the cross-sectional area in the carpal tunnel. So it's like scaphoid pisiform. Here, this pisiform is scaphoid. So you just measure in between this median nerve. You can measure that nerve and then compare. So if it's more than 2 or 2.8 means there are different cutoffs that have been suggested. Now we are also a part of the randomized control trial, which is going worldwide. My guide, Professor Michael Cartwright, is also a part of it, and I'm also a part of this study. And maybe it will come up by this end of this year. And believe me, we will have a clear-cut, paradigms how we have to move forward when we have these kind of cases. So where the NCS and ultrasound both will be integrated. And some interesting cases. So you can see this is flexor carpi ulnaris muscle. You can see the ulnar nerve, and you can see the ulnar nerve, how hugely it is increased. You can see it's in the middle of the screen, just in the top. You can see I will not have pointer options here. Here, this one. Okay. This one. Is my pointer working? Here is ulnar nerve, sorry, not median.
Yeah. So now it is, pointer is working.
Yeah. You can see this nerve. It is hugely increased, cross-section area of the ulnar nerve. This was a simple case of again, you can see this here. We are moving towards the arm actually, and this nerve will now the medial intermuscular, and then it just dips down and goes to the posterior. the medial part with the axillary nerve and then the axilla. So, uh, so this was a simple case. So you will ask me that this thing we are able to see by just palpating only. Why are you seeing with? Please try to understand. There are different other sides also. Yesterday there was a case where the median nerve was thickened in just in this forearm area where you cannot palpate and see. Believe me. So I'll show those cases also. How can I delete this annotation? It's coming again. Okay. Now we see. So here median nerve is, it's not a case of carpal tunnel, believe me. So it's just, again I'll show this play for you and again I'll annotate. So did the video play or not? Okay. This one. So this is the median nerve. Just see. This is the median nerve and is just proximal to the carpal tunnel. Now it will just enter the place where there is the pronator quadratus muscle. Okay, so you can see that the increased CSA is there. Believe me, you cannot palpate it. You cannot palpate this unless and until you see this nerve directly with the focus. Because anyway, you are not going to send always to a radiologist. So if you have this technique in your hand, you can easily diagnose this case. Here. You can see the increased CSA here. You can increase the increased CSA, and then again it goes to the forearm. Now it's just entering the forearm between the flexor distrum superficialis and flexor distrum profundus. So it's superficialis here. Again, once again. So this is the superficialis where I'm marking here. This is the flexor distrum superficialis, and just below that is the flexor distrum profundus. And here is the median nerve. You can see here is the median nerve. Coming on to CTS interventions. So carpal tunnel syndrome, there are patients, believe me, you'll ask them to go for a surgery, they will not go. They will continuously decrease their CMAP amplitudes. They will continuously suffer. They will continuously eat pregabalin, 150 mg, 300 mg, but they will not go to a surgeon. Try to understand. Surgery is a big this thing in India. We have answer. We have now answers for this. I'll show you how. Okay, so this is the median nerve that I showed. These are tendons. These are the tendons. Here is the ulnar artery. Here, okay, and we go from this side beneath, just beneath the transfer carpal ligament here. Here, so we go from this side just beneath the transfer carpal ligament, and we just hydrodissect it. So we go from here, from the ulnar side. So we just avoid the ulnar artery. Here. Ulnar artery is here, just lying here. So we just avoid that and go here like. And then we just hydrodissect it. We also hydrodissect from below and from median of this thing. So there was a study where they had compared 5% dextrose with some, 5% dextrose mixed with some amount of corticosteroid. They said that 5% dextrose with corticosteroid helps more. I don't believe. I think 5% dextrose is good enough for this hydrodissect. And there is a current branch is also coming. So in that video, that current branch is coming. The radial recurrent branch is coming out of the nerve. If the ulnar artery is there, you can see ulnar artery and pointing it. Just tendon. Tendon. Showing how I put the needle here. Going. How this will go? Okay. No, it is gone. So you can see the needle is coming from this side, from the right side of the screen. Actually, are you able to? You can see this screen, this needle. You'll just see now. Needle will appear here. You can see the median nerve. Are you able to identify the median nerve or not? Everyone has, in the center of the screen we have median nerve. See, you can. If you, are you able to see the needle coming here from this side? Are you able to see
Yeah, yeah,
the
yeah,
needle?
yeah.
Okay. So next video I'm showing you now. Now see needle is coming. I'm just trying to go over the median and just below the transverse carpal ligament. Now just I am over the nerve. Are you able to see the needle? I just have the median nerve here, and I'm just pushing to see. So already I am in the correct. So I've just given some amount of fluid here. The, nicely, the median nerve is actually separated from the.
Yeah, it is visible. Yeah.
You can see this median nerve is beautifully it is being separated from the transverse
Yeah.
carpal ligament.
Yeah. So, madam, in the meantime, uh, any comment till now? What he has told?
Sir, I've been using nerve ultrasound. I've not actually trained in it, but we have been doing it quite frequently at our center. We have a high volume center here, and basically a radiologist is helping us with it. Am I audible?
Yeah, yeah, yes.
Yeah, so a radiologist is helping us with it, and we have had, a few patients which we have diagnosed very well. There was recently a diabetic CIDP, and these patients are actually very difficult to diagnose only on a nerve conduction and EMG study. Uh, uh, of course, median neuropathy. Since I joined this particular center at Jabalpur from 2019, we have been doing it frequently. Corticosteroid injections, our radiologist was doing, but personally, my experience in doing it myself has been less because because of the issues with the point of care ultrasound machine actually. Um,
Dr.
so
Rajesh
we are not
Kable,
able to.
madam is telling us that point of care. So we have got in my clinic, I've got a 10 megahertz probe. So can I do this technique from that probe?
So ideally for superficial and small volume extremities, you should ideally have 12, 14. For example, I have two probes. Uh, the probe should be short linear, have a small footprint so that it can, glide over and show you the small anatomy. So you cannot use a large footprint probe. And you should at least have two probes. So one probe should be 5 to 10 to do the large girth extremities like the thigh and the legs, and the other we have is 6 to 18. So that works excellently. And if you have even a smaller footprint probe, for example, a hockey stick probe or something like that, then that's excellent. We don't have such a concentrated experience of neuromuscular ultrasound, but we have a fairly long experience. So probably I started doing ultrasound in 1988, 89. So now it's 11 and 35 years. So obviously during the course of that, probably Dr. Ujjwal gets 10 times my experience in a month that I get, but then I have 35 years experience.
So Ujjwal, are you there? Yeah.
Definitely, you have more experience, sir. There is no question about it. We have definitely, I have learned these things from you people only because I started in 2017 to learn a bit, and then 2018-19 I was started just doing these things, but maybe I was trying to go to the US at that time, but then COVID came, so I started myself only. Then Professor Cartwright asked me to come in 2022, and then I also went to Europe for some time. So I think we have finished with this. My screen is visible or not?
Yeah,
Now it is
Yes,
visible.
now
You proceed. You
visible.
proceed. Yeah.
Okay, so already you can see the needle nicely that it's coming. So it's a very
Yes.
high frequency probe. It's a 20 hertz probe actually. So it's a very, you can see the nicely these things are very much visible. If you have just the 18 to 8 to 13 or 8 to 14, whatever it is, like, it's that not that much nice this thing. So I have already hydrodissected from above, and now I will go just below. You can see I have gone below, and now I will again hydrodissect there also. I'll just go below. Already gone below. This is another case actually. So I've just gone below, and I'll just see. You can see that so already the above you can see this. So nerve is totally free of all this. You can see the nerve is totally free from all those adhesions and all, and it's just nicely bathing in that D5 solution actually. And you can see I'm going proximally and distally. So you can see the nerve is free of all those kind of adhesions. So it helps brief me, and maybe just one patient or one or two patients had come back to me. In that case, again, I had to dissect. It's not a big deal. After 1 year, one patient had come just for 1 month back. But then again, I had to dissect. It's not a big deal for me. It's like 5 minutes thing for me actually. So this is about this thing. We are also doing some things for headache actually. So we are doing this greater occipital nerve block. So it's like inferior oblique muscle, the inferior obliquus capitis, and the semispinal cervicalis. So here is the greater occipital nerve actually lies between these two muscles actually in the back. So it's a very easy procedure. Sometimes patients who are intractable patients of migraine and all, helps a lot. Sometimes patients come back, but then at least you know that yes, this patient has something related to the greater occipital nerve, and then you can block wherever you require. So I have used this procedure for some intractable headaches, and it helps actually. So you can see this is the nerve in between, just in the middle of the skin. I'm not doing an annotation again; it will be difficult for me to, so in just you can see in the middle, the nerve is sitting there, just between the semispinal cervicalis and the inferior obliquus capitis muscle. So that nerve sits there only, the greater occipital nerve. Just go from laterally and just just bathe the this in a lignocaine or whatever you want. If you want Buvecan, you can use all that also, and some steroid also. So I use some, but then steroid sometimes not required also. So already my needle is coming. You can see from laterally my needle is coming already. So you can see my needle just entering from laterally.
you can see.
Already it has entered into the muscle that semispinal cervicalis, and I'm just want to go to just want to go to that plane actually, that plane where this thing is sitting actually. The nerve is sitting actually, the plane between the semispinal cervicalis and uh, the inferior oblique. So I'm touching the nerve. So you do not need to blow the nerve actually totally. So you just want to cover the nerve and just give some amount of this, and it helps a lot. So I've just diffused some amount of this thing. Now I'm just above the nerve actually. So in that plane, that facial plane, already the drug is going, and that helps. Elbow pain, just tennis elbow or more. Believe me, there are some. Now I have got a series also where the patients who present with tennis elbow actually. So you diagnose, the orthopedician diagnoses it, but it's actually a radial tunnel syndrome. So it's radial tunnel syndrome. You are all this, esteemed people with so much of experience on. But if you just go and read back, if it must be knowing also, but if you're not knowing, just go back and read about radial tunnel syndrome. So one rehabilitation person from AIMS Rishikesh has done this study. We are also publishing a paper now, where they have seen that this just tennis elbow actually, the radial nerve is actually entrapped there in this kind of things, and it looks like tennis elbow, but it's not a tennis elbow. It's just not tennis elbow, but maybe a painful elbow along with radial tunnel syndrome. where there is pain along the radial nerve distribution. In tennis elbow also we have the pain here. But yes, if you have just the pain there and just on that that epicondyle, that's all. You do not have any pain radiating. Then yes, that may be a case of tennis elbow. But there are many cases, believe me, where there is radial tunnel syndrome along. And so what happens if you just give an injection blindly? It doesn't help actually. So we give these kind of injections also guided, and we do give both PRP actually, platelet-rich plasma, and we also give the steroids. The steroids with platelet with the good part with platelet-rich plasma is that you can go directly into the tendon actually, and you can just there's no problem in going directly into tendon. But if you are giving steroid, then you need to be a bit cautious, because if you directly hit the epicondyle, then that may be problematic for the patient. But if you are giving just the steroid, it's fair enough even. And what's the advantage here in the neuromuscular ultrasound is that you can just you can just see the probe tenderness. You can just tell the patient to move his distal extremities and just the wrist, the fingers, and you can exactly localize where the tendonitis is, where the epicondyle is, which muscle, because like it's a common extensor tendon. So there are different tendons which are going and attaching there. So there sometimes there is just in that maybe ECRB tendon, sometimes just maybe in some other tendon. So if you can localize the tendon specifically, and as you can see, my needle is just coming there. I have localized that already. That yes, this is the particular place, particular tendon, particular this thing where this. And I give PRP, mainly PRP, but if the patient cannot afford, a patient very poor, then we can give a steroid also. It helps, believe me. It's not always PRP which helps actually. And you can see I've just I'm showing this in a larger screen here. So my needle is coming, as you can see, and I'm just going just below that area, and I'm giving some so I will give the PRP here also, and then I will go a bit more proximally to here this place also, and then I'll give the PRP. So as you can see, my drug is just diffusing there. So it helps a lot, believe me. You are giving all those kind of splints and all, you are giving analgesics, patient is taking for months and months. Just a small, maybe a steroid or PRP helps a lot. Now this is a very interesting thing. So tongue NMUS. So we are in pipeline. This is a paper we are publishing here. Tongue neuromuscular ultrasound. So I'll just annotate here. So this is entrebelly of digastric. These are the two entrebelly of digastric. This is the mylohyoid. This one. This is the geniohyoid, and this one actually lower down. This one genioglossus muscle. So we are looking like this. We are putting the probe like this here. Yeah. So it helps a lot. Believe me, it helps a lot. This is a normal listing. There's no problem in this. But a patient comes to with me with inability to speak, dysphagia, and then see this. The annotation doesn't go. That's a very big headache. You can see the atrophy and all here in the muscle, tongue muscle, clearly visible here. There are some fasciculations also. It's not visible a bit. Now you can see the fasciculations here. Are you able to see that fasciculations clearly? Nice fasciculations there.
Yeah, visible.
Yeah. So this is very easy. Suppose if you protrude the trunk, the patient has some tongue tremor, whether there or not, you are just putting your head like this, and there's a busy OPD. Just put the ultrasound probe here. You will be able to see that. And believe me, the sensitivity is as high as 100%. So this is where the focus, that the point of care ultrasound is important for the neurologist also. As I said, in the US, they are extensively using this. Now see this video. It's a nice video here. So you'll just see after some time what's happening here. So this muscle is moving. You can see at the pointer there. The muscle is moving there. So it's a dystonia, it's a tongue dystonia, which was not visible otherwise. But when we do this neuromuscular ultrasound, it was visible. You can see the arrow there. Are you able to appreciate, sir? Encasing, sir?
Quite very good, excellent one. Yeah,
Yeah, yeah.
I can appreciate.
So it was this one. I'm giving an entry value of digastric. I'm giving Botox. So it helps you a lot, because sometimes what happens, the landmark techniques and all, where you are entering, what the vessel is there, some vein is there, and you are totally puncturing those kind of things. So, but here you see, I'm doing this in guidance of ultrasound. Nicely, my needle is entering in the entry value of digastric, and I'm just giving this. This you just saw the drug diffusing there. No, it will come again. I'll show you. Yeah. I just, yeah, just the drug went there again. Yeah, you saw that yeah, just because it's small amount of drug, so it will not just expand like this, small expansion. You want to see it again? I'll show once again. Yeah, are you able to appreciate, sir?
Yeah, we can.
A small amount of drug just diffusion there.
Yeah.
Diaphragmatic ultrasound, very important. when we are taking these patients prognostication value, I mean, whether these patients are, we are undergoing one study actually. People have done many at times, but for neurologists, we are doing this in this study. And whether patients of Guillain-Barré syndrome, myasthenia gravis, whether they are gonna land to, so we are doing bolo 1 2 3 4 5 6 crude. No, we have to go for this. You just see how. So this is a normal ultrasound. You can see the diaphragmatic excursion, nice diaphragmatic excursion, and you can see for this poor chap, there is no excursion at all, and the muscle is also hyperechogenic. So this was a case of actually of late onset LGMD with some respiratory involvement, and the patient had a severe this thing, but patient was not able to understand to this. I told him 100 times that you will land into BiPAP or this ventilator, but did not understand. And second day, the patient was rushed to the ICU in the night. So you can predict fairly well whether this patient will require a ventilator or non-invasive ventilation based on just this diaphragmatic ultrasound. Now coming on to laryngeal ultrasound. Is there any ENT colleague there? If there is, it's folded hand. I beg your pardon, and then I'll tell you the story. So what happens? The patient with there's lateral mid-journey syndrome, and when I'm not there in the ICU, so my anesthetic colleague actually, because this is a challenge that ICU people will see these patients, and critical care people will see, medicine will see, everyone will come and see the patient. Okay, no issues. Corporate sector, corporate culture, very good. Patient ICU person comes and just writes refer to ENT for this lateral medullary syndrome. Okay, please refer, no issues. The ENT person comes and just puts the laryngoscope and takes 2,500 rupees. Poor chap. Already just, spend all the money, on all the medications and whatever, variances. But just puts a laryngoscope and takes 3,400 rupees. Not required. I have this neuromuscular ultrasound. I'll put here and just see whether there's laryngeal palsy or not. I'll show you this video. So are you able to appreciate, sir, that one side the cord is moving, another side is not. On the right side of the screen, there is no movement, but on the left side, the movement is there. Are you able to appreciate that?
Yeah. We
So
can.
it's simple. You just put above this, tracheal this ring. Just put on the larynx and just see this video. You will be able to 100% understand whether there is laryngeal palsy, which side laryngeal palsy, how much is there. Not only in this, laryngeal dystonia, where you cannot document which muscle is there. It's a abduction dystonia, adduction dystonia, whatever it is. It's totally visible on this. I beg your pardon to all ENT persons. I do not have any intention to hurt anyone. But then, yeah. Now, here's a very important thing. You can see everything is white in the above is the normal thing, and the below is a person who had a post-stroke spasticity. Now I need to give the botulinum toxin. So where I would give the Botox, if I give in all those fibrous white areas, nothing's going to happen. Believe me, the drug is only going to diffuse from somewhere, some place, and then what? But we have a small pocket here. I'll show you that. Just I'll have the annotation here. I'll show you this. There's a small pocket here where you are seeing something black. So this is the place when if you give the botulinum toxin, you will benefit the most, because everything is fibrous here. Suppose if you give here, so everything is fibrous. If you give here, everything is fibrous. So just a small pocket out here in the FCR and here some maybe. If you give in these areas, Botox will work the most. So botulinum toxin always ultrasound guided in the US. They have abandoned the EMG. We are still using the EMG, but there they have abandoned totally. If at all they are giving it, if they want to give it, they are using it as an adjunct, not as the main thing. So now there, the ultrasound is the most important. Okay. Okay. Now this is just a Botox, this ultrasound guided Botox. So we are very much scared when we need to give in the pronated TDs. We are very much array pronated TDs, what muscle. So we'll put the needle and we will just, maybe we will just, do like this and see the needle is moving or not. Crude. So we have this ultrasound. We can clearly see we are going to pronated TDs. There is pronated spasm is there, and we can easily treat the patient. You can see the needle will come from this side. So that's an artery. I'm just pointing over the artery. So we have to just avoid the artery. We just go above the pronated and we give the botulinum toxin very easily. So why I know this is pronated only, because median nerve is just beneath this. So median nerve, there's the brachial artery is there. So brachial artery just goes beneath the pronated this TDS muscle and also with the median nerve. It just goes beneath that. So I know that this is the pronated TDS only. So I've just fast forwarded this because already we are running. This time is a bit here. So you can see the nice bleb in the muscle. You can see just nice the muscle, the drug instilled into the muscle. Again, I'll show you. See, so my needle already there. I'm just pushing the drug. Can you see, sir? The drug has just gone into the muscle.
Yeah,
Are you able to see?
Yeah, visible.
Okay. Okay, sir. So again, here this is the hamstrings. Actually, I'm giving the Botox. So middle is coming. You can see. So already entered the muscle, and next slide, I'll just show how the. So already I'm giving the drug here. There you can see. And also with the color. So if there is color, we are also sure that yes, we can put on the color and then see whether. So my needle is there and color is coming. So we are in the correct place actually. So we are in the correct place. We have already given the Botox there. Okay, again you can see the color. By the color, actually, this basically Doppler, power Doppler or color, whatever you can use. Doppler you can use. Doppler effect, you can just see that muscle is drug is diffusing correctly to that. Now, coming on to this is a very interesting technique, suprascapular nerve block. So we localize the suprascapular and suprascapular fossa, and believe me, patients come to us with post-stroke spasticity, and they are not able to lift their hand and all. And very easily we are able to do this procedure. So you can see this is the suprascapular notch here, and you can see the artery here. I've just put on the Doppler there, and that the artery, just the nerve lies just beside the artery actually. So we just go from here, just localize the artery, and just go beside that, and then push the drug. I'm actually pushing it a bit fast forward because you are already running behind the schedule, and you can see my needle is coming in the left screen. You can see my needle is coming here into that fossa already, and in the right screen you can see I am already instilling the drug. So the whole this muscle is coming up actually. So this is the thing, and you can see the results. The patient is not able to lift here, and you can see the patient can totally lift this. So it's a miracle. Just after 5 minutes, you will see the patient has improved, and then the patient definitely has to get the continued rehabilitation, and then patients are benefited. So if the patient continues the rehabilitation, then patient again this patient has developed post-structural frozen shoulder, and then we can just how the patient after how the patient is able to lift this hand like this. Now there are some interesting cases I'll just show. So this is the radial nerve in the radial tunnel. So this is the radial nerve in the radial tunnel. So radial nerve actually from here it enters the radial tunnel between the two heads of supinator actually, and there is one arcade of Froese here around here, arcade of Froese, and when it enters, so if there is thickening here, so it may be the compression from arcade of Froese. But then this was a different case. This was uh, um, a case of amyloidosis. So there was thickening here, and then from there we went back and said that yes, there's thickening of this radial nerve, and then we did all that. There was some proteinuria was there, and then we came, went back, and then this whole diagnosis was able to, we were able to confirm this diagnosis. You can see this supinator tunnel, and then is entering the the extension compartment of the arm. This was a case of cubital tunnel actually. You can see this ulnar nerve just below the flexor carpi ulnaris. I'll show you. I'll just annotate once, and then you can follow this nerve actually. So this is the ulnar nerve here, this one, and this muscle actually is the flexor carpi ulnaris muscle. We are just near the elbow here. Here we are. Here, and this appearance is also called the breast with the nipple or the cherry on the cake appearance. And as you can see here, are you able to appreciate the nerve? I'll show you when it's thickened. So when we are going proximally now, can you appreciate the nerve is being thickened here? Can you appreciate the nerve is thickened here? Yes. This is the area where the nerve is. You can see the nerve is thickened here. You can see the nerve is fairly thickened here. So this was a case of cubital tunnel actually. And again, you can see this case. This was again a case of Hansen's actually. So ulnar nerve is, you can see, it has come to the medial epicondyle now. And after that, it will be hugely increased from this point of view. Now this nerve is just near the medial epicondyle. And you can see as we go proximally, the nerve has a huge increment in the cross-sectional area. Now it has gone down now. Now we are just near the breast nipple, that thing. But we are above this elbow and now coming on to muscle ultrasound, how do I get rid of this annotation? Once it's annotated, it's forever. It's very difficult to remove this thing. Oh my god. Okay, so let it be that. So like so coming on to muscle ultrasound is very important this thing study to classify muscles, muscular conditions, muscular pathologies, especially muscular dystrophies, inflammatory myopathies, and things like differentiating from amyotrophic lateral sclerosis. Sometimes where there's dual pathology, this is the normal muscle. So we need to have, home pages. So you need to have the whole picture in your mind. So if you are putting here, even if in your sleep, you should know that yes, this muscle is there. So anatomy should be very much clear. So when you are putting the probe here, you should be very much sure that yes, this is the muscle should be there, what this should be nerve should be there. Then only you will be able to, appreciate the anatomical variations, because there are some anatomical variations are there. But if you are able to, that yes, this is the thing, this is the picture should be there at this point, then only you will be able to understand the pathology. So a nice annotate this muscles in longitudinal section. So but now we are not putting the probe like this. We are putting the probe like this actually. So we are seeing two layers of muscles with different layers of orientation, and superficial and deep muscles. Most likely, this has been taken from the soleus and the gastrocnemius, the lower limb, and boundaries of muscles are clearly visible, as the epimysium surrounding the muscle is highly reflective echogenic structure. So so if you are confused, you just go for the epimysium. If epimysium is well visible, just below the muscle will be there. This is the Heckman score that I was talking about. So normal is like grade 1, grade 2 is increased muscle intensity with distinct bone echo, grade 3 is marked increased muscle intensity with reduced bone echo, and grade 4 is very strong muscle echo. So grade 4, nothing will be visible. So this will not be visible. In grade 3, it will be very, very faintly visible. In grade 2, it will be visible, but less than normal, and grade 1 is normal. So you can clearly see here. So again, I use the annotation. So as you can see here, this is the bone. You can see this is the bone. So you can see here the bone is visible, but not that much clearly. Here it's a very faint line here of the bone. Sorry, this one. This is the line of the bone, and here is totally not visible. Here we do not have the bone, so we do not know where the bone is. So so this is the Heckman grade 4. Now the importance here is that when you see this kind of muscle testing, so what is the take home for us? If we are going to do the biopsy, suppose we want to send the biopsy, so there's no point in sending from the Heckman 4 this thing. You can send from Heckman 2, maybe 3. Then one thing. Second thing, if you are very much sure with the EMG and the neuromuscular ultrasound that yes, we are dealing with a myopathy, why not straight away go on to genetics? So yes, now we have recommendations like this, that we can just bypass the biopsy at all, because it's a painful procedure, and sometimes patients are not ready for it, and they loiter here and there. Sometimes now we have even therapies for some muscular dystrophies. General physician will ask me, what you are going to do? Yeah, you are going to go for a biopsy, nothing is going to happen. Believe me, there are some inflammatory myopathies. There are some myopathies now we have treatment for those myopathies, especially in some congenital disorders and all. We have some gene therapies and things like that. So if we are able to diagnose it without pain, so that's nothing better than that. So definitely a non-invasive thing will always win over the invasive thing, mind it. So basically it's a non-invasive technique. Definitely it wins. If suppose a patient, I want to do the EMG, many people will not be ready, but if I do want to ultrasound, everyone is ready for that. So that gives a cutting edge actually. Okay, so this is the ultrasound appearance of specific neuromuscular disorders. So as I said, in muscular dystrophy, it may be increased. In congenital myopathy, it may be normal to increase. And but very important thing here is that the muscle thickness actually sometimes it increased. So I had a patient last month with inflammatory myopathy, which people were wondering whether it's a case of maybe a DMD, maybe because the presentation was a bit atypical, and patient did not have hypertrophy, and patient had some calf pain and all. This was a child actually. But what I saw, it was a very bulky muscle with lots of edema in it. I do not have the picture here. I'd love to show you that. And I suspected that yes, it could be an inflammatory myopathy. Patient's parents were not at all ready for any test, because they had seen one pediatrician, one another neurologist, and then they had did some tests. Maybe the CPK was done, but that was not conclusive. Then this patient had a bulky this thing. I repeated this. I told that I will treat you for 100%, and I did the CPK also. So now that was increasing CPK, because at that time maybe the patient went early and there was no CPK increase. And then when I was convinced that yes, I can treat this patient, I give the steroids, and the patient is doing very well. So So it's like if you have some other, as I said, as this talk reads actually, the the heading of this talk reads the third eye. So always this third eye helps actually. And as already I have uh, told that there's some moth-eaten appearance. So the first slide that I had the tongue USG. So there was some atrophy there because there was annotation. I was not able to show it properly, but there was atrophy. So it's a moth-eaten appearance. So that's there in anterior horn cell patients, and then definitely fasciculations and things like that. Those things are very important. And believe me, this happens very early. So it's a very important tool because we can pick it early. That's also a very important advantage. Now, in this patients of inclusion body myositis, all other muscles are atrophied except FCU. So if FCU is very much visible and other muscles are atrophied, so you are very much sure that yes, this is a case of, even if you know the principle of myopathy, muscular dystrophy, everywhere we talk of differential atrophies. So this differential atrophies, it's not always visible by eyes. If you can just show on ultrasound, it's the task is easier for you actually. And obviously quantification of muscle echo intensity increases sensitivity of diagnostic neuromuscular disorders. And now Dr. Van Elfenens, who is also my guide in this thing, because when I started way back in 2017, I had a long chat with her, how should I go about it and what. So she advised me to do this subspecialty, and she is developing a software based on different age, different ethnicity, different sex, and she is developing a software. And in that, because suppose a patient with a 90 years of age and a patient of 18 years of age, the muscle will not be the same. Definitely the muscles of 90 years will be more fibrous, there will be more fibrous tissue than the muscles, and fat will be replaced in that patient. So the normal values should be actually, so that will come with the machine itself. The machine, the Cadwell is doing this research, and with this Professor Van Elfenens, and most likely they will come up with some softwares where you can just put the probe, you can just tell what's the age, what's the sex, what's the how much distally you are from the medial epicondyle, and then they will tell that it's myopathy or not, or you are dealing with some muscles like that. Now coming on to dynamic muscle ultrasound, already myositis, as I said, when I put the probe in that boy, the tender probe was there, and then muscle edema, and definitely dynamic muscle ultrasound also helps, like in fasciculations, dystonias, things like that. You can see this nice fasciculations here. Fasciculations already I have shown in the tongue, but you can see here also this fasciculations clearly. Important is that if it happens in deeper muscle, suppose so fasciculations are superficial, you will be able to see it visual on visual this thing. But here you can see the fasciculations are actually in the deeper muscle actually. So it will not be visible on the naked eye. So here the ultrasound actually helps. You can see the fasciculations here. Are you able to appreciate the fasciculations, sir, in the deeper muscle?
Yeah, it is quite good. Nice.
Yeah.
Nicely we can appreciate it.
Yeah. So this was again a case where we are not sure what the lesion, what's not. But what happened actually, you can see that this is long head of biceps and short head of bicep femoris actually in the lower limb. So there's a tram track appearance of bicep in the middle, you can see. So now we also know from the EMG days that if we can show that biceps femoris, the short head of biceps also has been involved, that means the lesion is above actually. Sometimes we cannot get these fasciculations on the EMG, but if we can see on ultrasound, we can localize this patient. So this patient was deemed to be a case of ALS by some other neurologist, by some other physician, to be very frank. And then the patient came to me, and then I did this ultrasound for him. I was not sure what I'm doing. So it was just late evening, 8 o'clock. No patient was there. So I was just enjoying ultrasound, doing this patient, ultrasound for this patient. And suddenly I saw this, biceps femoris fasciculation. I was not 100% sure that it's something above. And because this was that was there in only one limb. So I got the MRI lumbosacral spine, and there was a huge disc there. So actually, it's not only about just fasciculations. It just seeing fasciculations means always ALS. It can be anything actually. And you can see the nice fasciculations here. Again, I'm showing these fasciculations here. And already I have said that it's more sensitive in detecting fasciculations to ultrasound more than EMG actually. And these are the areas that we need to scan. These are the protocols that have been fixed by the International Society of Neuromuscular Ultrasound. The clinical electrophysiology and neuromuscular ultrasound, now they have been combined. There is an organization called Clinical Electrophysiology and Neuromuscular Ultrasound, and Professor Van Elfenens is the president now. And inhomogeneous increase of echo intensity with atrophy are seen in neurogenic disorders. So sometimes it's difficult to differentiate between neurogenic and myopathic process. But if you see keenly, if you measure the muscles, different muscles, affection of different muscles, differential involvement, everything you can see, and you can just sit down, you can write the chart here, and then you can definitely come to a conclusion. It's not that much tough actually. Coming on to congenital muscular dystrophy, muscle echo intensity is severely increased. I had a couple of cases, and extensive histopathological muscle changes, as we already know. Bethlehem myopathy, there is some central shadow sign is there, and that's very classical of this muscle disease. And other congenital myopathies. Why I'm continuously putting these slides, because in children EMG is very tricky. So if you just take these patients for EMG, they will not put volition. If there is no volition, how can you do the EMG? EMG में तो पहले उसको बोलना पड़ेगा कि तुम भैया तुम पैर को खींचो, वो तो रोते रहेगा, हाँ हूँ करते रहेगा, आप कभी EMG नहीं कर पाइएगा, बिलीव मी. वो सब कहने की बातें हैं. अगर कोई बच्चों में EMG is very very difficult, but ultrasound is as simple as. वो कितना भी रोएगा, अल्ट्रासाउंड लगा दीजिए, देखते रहिए आपको जो देखना है. लेकिन ये EMG में क्या है कि उसको आप घुसाते हैं, उसको वॉल्यूशन तो देना पड़ेगा. वो वॉल्यूशन देगा नहीं, छोड़ देगा हाथ को, कभी पैर को ऐसे कर लेगा, is very difficult. And then it's already needle is in. Patient is panic. Patient relative is panic. Father is panic. He can put the hand on your throat. So it's easy. You have to do ultrasound. You just remove the probe. No pain, nothing. So you can directly go for the ultrasound. Inclusion body myositis, already I have told. Motor neuron disease, spinal muscular atrophy also it helps, and especially the quadriceps muscles show most abnormalities. Although the moth-eaten appearance and all are also can be seen sometimes here, but the most important thing, the quadriceps muscles here have the characteristic findings. ALS already we have discussed. So what are the advantages? Just final slides. So just 1 minute I'll take more, and then I'll finish. USG can detect changes in early or pre-symptomatic disease. So if a patient has a problem, सबसे पहले क्या होगा? सबसे पहले उसको सिम्टम होगा, यानी कि उसको कार्पल टनल है तो उसको ये पेन होगा. बिलीव मी, तब तक एनसीएस में कुछ नहीं आएगा. जैसे कि वीपी में कुछ नहीं आता है, पेशेंट को ऑप्टिन्यूराइटिस हो जाता है, लेकिन पेशेंट को उसमें कुछ नहीं आता. सबसे पहले first thing that will happen will be the symptom if the patient is intelligent. सबसे पहले वो होगा. सेकेंड थिंग होगा, अल्ट्रासाउंड में आ जाएगा. थर्ड, जब उसका पूरा डैमेज हो जाएगा तब वो इलेक्ट्रोफिजियोलॉजी में आएगा. इलेक्ट्रोफिजियोलॉजी में हरदम बाद में आएगा, पहले अल्ट्रासाउंड में आएगा. लेकिन हाँ, अगर आपने इलेक्ट्रोफिजियोलॉजी और ये दोनों मिला दिया तो आप सबसे होशियार आदमी बन जाएंगे. That is what my professor used to say, and I also believe on that. And definitely it's a less cost, easy availability. You can just put your ultrasound. So I put my ultrasound here when I do the BZOPTs, and I just take the probe and just see like this. If I have any confusion, I just make my patient lie down here and just see. And if there's some detailed study, I even charge for it because I'm a certified RMSK and I have a fellowship in ultrasound. But then for many of patients, I just do use it as a focus, as a point of care ultrasound. And I do it and give the and I tell that this thing you have, and you can there is no requirement of any sedation, no radiation exposure, and moderate sensitivity and specificity. But now with high resolution ultrasound, again it has gone to very high sensitivity, very high specificity also with high resolution. This is earlier thing. And so non-invasive ultrasound as a screening tool in suspected neuromuscular disorder, in sharp contrast to another a frequently used tool. EMG is a measure of function, and ultrasound is concerned with structure, and application of dynamic ultrasound can provide bridge between study of muscle structure and function. And metabolic myopathy is one exception. Children in less than 3 years, a bit exception, but we cannot use there. The study is coming up for that and protocols being made. Thank you very much. This was my Wake Forest University where I did my fellowship. Wake Forest University, and this was my one professor, and this was my Professor Cartwright, Professor Michael Cartwright. Is a well-known figure, a well-known figure in this field. Thank you very much. And this is Dr. Valen Filnes. So I was there in Europe, and she's Valen Filnes. She's a very well-known figure in this neuromuscular ultrasound. Thank you very much, sir. Thank you.
Madam, is there, are you visible to see any questions in the chat box? Please see.
Sir, there was only one question, I think, and I think Dr. Ujjwal has already answered. So it was about, I think, in what way neuromuscular ultrasound can help therapeutics in neurology. I think that is what the question was.
All therapies I have showed, which
Yeah.
which people do not know, that I also have showed.
One question is visible. How can neuromuscular ultrasound complement traditional electrodiagnostic test in the diagnostic peripheral neuropathies and myopathies? So you're going to stop sharing that visual, and then we can have discussion.
Yeah. So already I have answered this question actually, but again I have to repeat. I'll just tell that as we know, symptomatology comes first, then comes structural changes, and then comes the electrophysiology changes. So when we are complementing these findings of neuromuscular ultrasound with our clinical and with electrophysiology, so clinical is always first. So if a patient comes to you, you cannot avoid the clinical. No. That's very important. You should definitely know how the progression of the disease. So अगर आप अल्ट्रासाउंड ऐसे एक आंख बंद करके आपने ऐसे सटा दिया ऐसे करके, अरे ये तो एलएस है, fasciculation हो रहा है, नहीं एलएस है ही नहीं, उसको सर्वाइकल रेटिकुलोपैथी है, इसीलिए वो हिल रहा है ऐसे. So clinical is always the first, number one. Number two is the neuromuscular ultrasound along with electrophysiology. So it always complements it. Why this technique has not been popular so far till last around 1 decade, maybe 5 years, 10 years, even in the United States, because this was sorry sir if there's some radiologist studies they're sitting here, I'm sorry, because this was with the radiologist only, and because clinician always used to fight with radiologists. They take their they use them, but try to fight that radiologist ने गलत रिपोर्ट दिया, उसने गलत दिया, ये किया, वो किया. अरे भाई जब आप ही के पास है तो जो आप ही को देना है वही फाइनल है, बात खत्म. तो आप ही बताइए क्या चीज है ये. तो the thing is that if you complement, no one is ready to complement. So everyone is just putting his shirt like this. So I am the EMG, I am the first. So another radiologist is telling that I am the USG, I am the first. No, you are both equally important, and you come together and just now find out what's the reason. Go to the patient. Try to in the benefit of the patient. So now the neurologists have taken this in the US, and now there is no debate at all. Now there are several papers that are coming up that the neuromuscular ultrasound is a great thing and all, because they have taken it up. But when the radiologists were telling, they were telling, no, this is a far thing. They are telling like this. So it's always complementing actually, and this is a complementary role in with electrophysiology. So it goes hand in hand. It's not a separate thing. Yeah.
Yeah, Dr. Rajan Chaudhary, any question from Dr. Ujjwal?
So this was a very comprehensive and extensive talk. Although we had some, the quality got marred initially due to the poor internet connection, but later on it improved. And the
I have a very bad luck today. My internet is gone. I am connected with a mobile. I am sorry for that.
Okay.
The first time this internet is gone, I don't know what has happened. It's raining terribly here in Ranchi. It's raining terribly in Ranchi. It's raining cats and dogs, and internet is totally disrupted here.
Correct. So we had an excellent and a very comprehensive talk, and so like a clinical talk, you did not focus much on the technique of the ultrasound or the how to adjust the image, etc., which is again anyone who has to learn will take a couple of years just to master how an ultrasound image can be manipulated before you can move on to all these specialities. So very well done, very nicely done, and excellent.
I would seek your blessings also, because you have been doing 35 years. I mean, I'm really because
I mean, this is like
There is a question from
meteorology.
my
I mean,
side.
meteorologies are
Can I ask a
getting better.
question?
So
Yeah, Akash.
yes, sir.
Go
Please,
ahead.
please, sir.
Is this technique a observer-dependent technique, or you have AI and other modalities to perfect the diagnosis?
Perfect. That's a perfect question. So nowadays, basically, point of care machines have AI technologies also. So they have like C nerve. They have got this C nerve technique. So you put the probe here in the supraclavicular fossa, and they will point out that yes, there is the brachial plexus. So you point out the here in the maybe here, and you put like the hand like this. They will point out this the supraspinatus tendon is there. So these AIs are now coming up. In GE, I have a GE machine, a Venu Go, it's called. So it's a point of care ultrasound machine. So it has got that. But believe me, if you are well versed with these things, AI doesn't help. For the beginners, it may help actually. But if you are well versed with ultrasound, for beginners, maybe for learning it may help. But AI doesn't help. See, the whatever human will do, AI cannot never match actually. That's what I think. Sir will be.
we can
Yeah.
say at least now it cannot. We don't know about the future.
Yeah.
At least for
So,
now,
Dr.
we use that
Namrata,
security.
so do you think that days of interventional cardiologist like that, something like interventional neurologist is coming up in the future? Because he
Sir,
also showed something that even for laryngoscopy there is no
Ma'am
need.
will always have praises for me because she is my senior from Bangalore Institute of Neurosciences. We were in the same unit actually.
Sir, so already at our center, we have an interventional neurologist. She's trained from NIMHANS, and she has been doing this ultrasound for us. And it has helped us as a neurologist to actually diagnose a lot of complicated cases like, diabetic CIDPs and some variants of CIDPs like MADSAM, and which we couldn't actually pick up on an MRI. Sometimes I don't know why MRI never showed. In one particular patient, we had this, and so it's not like the days of interventional neurologists. They are already there.
Yeah.
Uh,
So I think, or I will lastly, I will just request you to give your take-home message for this talk and for our audience. What's your take-home message?
So, sir, my take-home message is as a clinician now, point of care ultrasound is something which we all need to be aware of, and probably uh, start learning it if possible, because in like Dr. Ujjwal pointed out, so many patients he could help with his machine and with his knowledge. It is still developing in certain areas, it's operator dependent. So there we all are facing problems. Some cases which I referred to, so we have two radiologists, and some cases were not picked up uh, because of the operator dependability and operator, you know.
Yeah.
So those are two things that I thought were important. Another thing is intervention with these machines. Yes, hydrodissections we haven't focused on, but yes, corticosteroid injections, they have been there for long, I think. Most rheumatologists are doing that, and radiologists have been doing that.
Yeah, thank you, madam. So, Dr. Rajan Chaudhary, your take-home message?
So, sir, for starting this, for a clinician who wants to start this, so my take-home message will be appropriate equipment. So you must have high-frequency probes, which should ideally range from 5 to 20, from 5 to 10, or maybe from 4 or 3 to 10 to take care of the larger guts, and for the higher frequency for the superficial lesions or the less thinner anatomy. And in fact, it has been my observation that for the superficial structures, this can match or sometimes excel over MR as well. So point of, neuromuscular ultrasound is not to be pitied or to be slighted. So no need to kind of feel sorry in front of MR. So that
Yes.
is another.
Just one point, sir. I'll just interrupt you. 1 second, just. Uh, So what sir is told is 100 by 100% correct, because what is there? Na, MR neurography, we are very much, boasting about MR neurography. But 99% of the cases, they do not have these dedicated coils actually.
Correct.
And when they do not have these dedicated coils, the nerve doesn't look great actually. But with these high resolution ultrasound, it's much better, believe me.
Much better.
Sir already, I had missed this. Thank you very much, sir, for pointing out that. Yeah.
So in proper hands and with a good knowledge of anatomy, and even if you don't have a good knowledge of anatomy, if you have a patient, you can maybe call the patient back. That's what we do. I mean, we don't know everything about the human body, so we call the patient back in a couple of hours. In the meantime, read up the anatomy and then do the patient. So I must admit to that part of. So good technique.
That's always there.
And good equipment and good training.
Great. So, Dr. Akash, now Dr. Patni left. So, conclude this whole talk, and then we will wind up. Dr. Akash.
I think from what I have heard is that this particular branch of medicine is not very healthcare providers are familiar with it. So there is need for popularization and for education of the healthcare providers regarding the benefits of this branch of medicine, because the conditions which it caters to are ubiquitous and they are very prevalent. So there should be more CMEs on this topic. There should be some guidelines printed on the role of this technique for various disorders, and all the healthcare providers should be sensitized. And it is a great effort from Cme India group, family to have sort of taken up this topic for today's CME. So this is my take-home message, that this needs more awareness and more sensitization to healthcare providers.
Yeah, thank you, Akash. So I think I have a huge appreciation for Dr. Ujjwal Roy. Something new you have given to today to all of our audience. I think this will create. We have talked, I think, more than 1 hour, but still it was so interesting that nobody was bored what is happening, even in spite of the poor internet connection. So I think there will be a huge interest now to many of our audience. I also sincere thanks to Dr. Rajan Chaudhary, Dr. Akash, Dr. Namrata, and lastly Dr. Sweta. Wind up the session, and then we can have a good night. So Dr. Sweta.
Yeah. Thank you. Firstly, I'd like to thank Dr. Ujjwal Roy sir for the wonderful session and for giving us your valuable insights regarding today's program. And I would like to also thank our moderators, Dr. Namrata ma'am and Dr. Rajan sir. And this show wouldn't have been possible without Dr. N.K. Singh sir. So thank you so much for the platform, sir. I'm sure that the insight generated from today's meeting is going to help doctors in their clinical practice. So we're extremely grateful, sir. Thank you so much.
Thank you.
And
thank you.
I also thank the USC team basically for providing the logistic support and the online platform for these continuing meetings which are held every month. Thank you very much.
Thank you. Good night to you all.
Thank you.
Thank you, sir.
Good night, sir.
Thank you.
Good night,
Thank you.
sir. Good night, ma'am. Good night.